Sure, I'll just throw that in my pocket. All right, thank you. And to try and kind of change gears, we're going to spend the last session. Thanks for your patience sticking it out for the day, and everyone online for attending as well. Hopefully, I'll keep us close to only an hour behind in the end. So we're going to sort of change gears now. We've spent obviously a lot of time talking about allergic rhinitis. That was really the focus of the masterclass and immunotherapy. But what I want to do now is talk a little bit more about the different non-allergic forms of rhinitis. And I'm really going to focus primarily on two sort of broad groups, which are the kind of chronic, predominantly infectious rhinitis that we typically see in young children, and vasomotor rhinitis, which is the most common form of non-allergic rhinitis that we'll see mostly in our older kids or adults. My only relevant disclosure is that I was on the National Advisory Board for MEDO, the makers and or the distributors, I guess, of Dymista in Canada, and that's relevant as a treatment for vasomotor rhinitis. So very quickly, I'm just going to present a case of a young woman that I saw a couple of years ago here. She was a German national who had a long history of allergies, and as David was saying earlier, basically, every patient that we see who's had any degree of rhinitis has been told that they're allergic. They assume they're allergic. The patients come to our clinic saying, I'm here for my allergies. And of course, as you all know, as allergists, or those of you that are allergists in the field, a lot of them aren't allergic. So this woman had a long history of nasal congestion, clear runny nose, occasional sneezing, complications like mouth breathing and snoring, frequent throat clearing and a globus sensation, frequent frontal headaches. She didn't have any real seasonality, which of course is also not uncommon here, where we don't really have an awful lot of seasonality. And she identified dust, but also cold air, strong odors, spicy and salty foods as her triggers. And she had had a previous trial of intranasal steroids, which she didn't find to be helpful. We'll come back to that case at the end of the talk. So look, we know, patients know before they come to see us that they have rhinitis. And again, most of them assume it's allergic. If you have a history of either nasal congestion or chronic rhinorrhea, either out front or down the back of the throat, histories of sneezing, nasal itch, then you've got rhinitis. The question then is, what kind of rhinitis do you have? And again, a lot of people are frankly unaware that there are non-allergic forms of rhinitis. I've even had family doctors say to me in the past, well, if you've got rhinitis, then you have allergies, don't you? Like, isn't that just an automatic? And again, it's amazing how little awareness there is about what are really common phenomena in the different non-allergic forms of rhinitis. So, of course, we've had a lot of talk already about allergic rhinitis and a little bit of a touching on of local allergic rhinitis, which is patients who have classic allergic rhinitis symptoms, but negative skin or blood testing. And if you do nasal biopsies, you can see evidence of sensitization at the mucosal layer or level, but that you don't see systemically. But we're really going to talk more about the non-allergic types of rhinitis. And there is, of course, the overlap where some patients who have allergic rhinitis also have a significant non-allergic component to their rhinitis. And so, again, some of the things we're going to talk about apply to them. So broadly with non-allergic rhinitis, there's different types. The ones that I'm going to talk most about are vasomotor or idiopathic rhinitis and chronic infectious rhinitis, but there's also things like gustatory rhinitis and alcohol-induced rhinitis. There's hormonal and drug-induced rhinitis, and things like NARS, which was mentioned earlier, non-allergic rhinitis with eosinophil syndrome. And I'm not going to speak in any length about any of these other ones today. And look, there's a long differential diagnosis for rhinitis that it may not be, either one of the non-allergic or allergic rhinitis. There's other phenomena. I guess the most common ones here are nasal septal deviation, adenoid hypertrophy, especially in children, pharyngeal reflux. Some of the others are less common, but things that we have to have an index of suspicion for. I saw a woman just the other day who has a long history of rhinorrhea without really any other symptoms. And I became worried about the possibility of a CSF leak. Luckily, she had already had imaging that was reassuring in that regard. So as was mentioned right at the very beginning today, allergic rhinitis is very common. It's the most common chronic condition that affects children for sure, and really anyone in the general population. There's no other condition that affects up to 30% of the population and 40% in children. But non-allergic forms of rhinitis are frankly equally common and affect, again, depending on the study you look at, anywhere between 20 and 50% of the population. So we're talking about really, really common phenomena. And again, about a third of patients with rhinitis end up with overlap between the two, with features of both allergic and non-allergic rhinitis. And as has been mentioned, so I'm not going to go into huge detail here, rhinitis, whether allergic or non-allergic, does have significant impacts on quality of life and general health. And, you know, we are, I think, better now at appreciating the impact this has on school and work performance, the concept of presenteeism beyond absenteeism, where even if you're able to go to work or school, you're not able to perform at your best, you're not achieving your potential. You know, we know studies with allergic rhinitis in college students dropping a grade point in their summer exams compared to their midwinter exams during their pollen season. So, you know, I think we all take these phenomena seriously and appropriately. Now, looking at some of the different other types of rhinitis. So first, acute infectious rhinitis, a regular cold. And again, we have to appreciate the impact that these have. For example, a huge percentage of people with just regular acute viral rhinitis symptoms end up with, frankly, unnecessary antibiotic prescriptions. And in one recent paper, estimating that 60% of all antibiotic prescriptions written are being written for acute infectious rhinitis. And so, you know, again, we have to do a better job in our stewardship of trying to make sure that patients aren't being subjected to unnecessary treatments. Acute bacterial rhinosinusitis, which sometimes requires antibiotic therapy, but very often can be managed conservatively. High-dose intranasal steroids for uncomplicated acute rhinosinusitis has been shown to be a very effective treatment option. And again, then we decrease the risk of adverse effects and resistance developing. The main thing for that really is the duration of symptoms. And so when I have patients who say, well, they've been treated for sinus infections, I always ask them, tell me about the symptoms you were having at the time. And then very importantly, how long were you having the symptoms for before you were started on an antibiotic? And very commonly, patients will say, well, my nose got more blocked and I got green discharge and I went to the doctor after 5 days and they gave me an antibiotic. And that's almost certainly unnecessary. And so, you know, we have to remember that these kind of symptoms are simply normal cold symptoms until they've been at least 10 and preferably closer to 14 days before we should be thinking about antibiotics in most cases, unless they have more toxic and more severe symptoms, which is not that common, frankly. One of the things that I see, and David was alluding to this earlier today, and we see this very commonly because we're both pediatricians, are the kids who have really just chronic infectious rhinitis. And again, as David mentioned, all of these patients are told that they've got allergies. Most of them are being treated for allergic rhinitis with lots and lots of antihistamines and then often nasal steroids as well, but lots of antihistamines that really aren't going to be helpful for them because what they've really got is a form of chronic infectious rhinitis. And viruses driving this sort of inflammation is the most common, much less often bacterial and very rarely fungal. And we know again that viruses are the cause of most acute infectious rhinitis. But in these young kids, they get either persistent or recurring lingering cold symptoms. So these are kids who are getting cold symptoms on a monthly basis, but not just you know, the normal sort of 5 days of symptoms. Their symptoms will often last for weeks. So I have patients where they'll say, well, but it's only when they get a cold. And I'll say, well, how often do they get a cold? Well, every month or so. How long do they last? Well, 2 or 3 weeks. Well, they're sick more than they're not sick. So these kids often have this very predictable pattern of recurrent lingering illnesses. They very often have cough and very often are being treated for possible asthma, even though most of them don't have actual asthma. They often have sleep disordered breathing. They often have evidence of eustachian tube dysfunction with either recurrent ear infections or at least ear effusions, and that may be affecting their hearing and speech development. They may have a degree of adenoid hypertrophy as well. They are very typically very obstructed, a lot of mouth breathing and snoring. A lot of times the family may not even notice how much they're mouth breathing. The child will be sitting in front of me with their mouth hanging open, and I'll ask the family, do you notice it? Do they breathe through their mouth or their nose? And they're not often aware of it. And say, well, he's been mouth breathing the whole time we're sitting here talking. They often have rhinorrhea. It's often varies between clear or cloudy or yellowish. They don't have a lot of itch. They may wipe their nose a lot because of the rhinorrhea, but they don't necessarily have pruritus. They don't get conjunctivitis, but they often have dark circles under their eyes from chronic nasal congestion. They often have coughing and throat clearing. And again, because viruses predominate, these symptoms tend to be worse in the fall and winter months. And they may have irritant triggers like smoke and strong odors and cold air of bothering them. And very, very commonly, they've been given a lot of antibiotics before we see them. They've also very typically been given lots and lots of antihistamines, as I mentioned earlier. These kids come in having been taking Arius and Zyrtec frequently and regularly and really without any benefit. There's really no role for second generation antihistamines. Now, I'm somebody for years that has railed against the use of first generation antihistamines for allergic conditions or type 2 conditions. There's really no good role for first generation antihistamines for allergic conditions. We should be really exclusively using second generation antihistamines. And now with the advent of parenteral cetirizine, I'm hoping that'll translate now to the hospital and training setting, and we can kind of be done with a lot of the first generation products once and for all. However, for non-allergic chronic infectious rhinitis in kids, there is some evidence around the use of first generation antihistamines, especially if combined with a decongestant. It's one of the very few situations where these sort of medications can be beneficial. There's evidence of their effect on upper airway cough, and there's evidence of clinical benefit for the nasal congestion in kids with chronic non-allergic infectious rhinitis. And in kids who have either persistent or frequent symptoms or complications like ear effusions and lots of upper airway cough, a trial of intranasal steroids is always appropriate. Now, they may not always respond. As we've talked about earlier, allergic rhinitis tends to respond very well to nasal steroids. It's just that they need ongoing treatment because it doesn't cure their allergy. But with non-allergic infectious rhinitis in young children, about 2/3 of them will respond to a good trial of an intranasal steroid. So about 1/3 don't respond. But if they have frequent symptoms or complications, it's appropriate to have a trial of an intranasal steroid. So again, second generation antihistamines not effective, but first generation antihistamines and decongestants can be beneficial symptomatically, and a trial of nasal steroids can be helpful. So then shifting into vasomotor rhinitis, which is, again, something I see very, very commonly in my practice. Many of the adults that come in to see me with nasal allergies really have a classic history of vasomotor rhinitis. And the history will often differentiate it. So, people will say, well, it's got to be based on the testing. And yeah, there is, of course, a role for testing. But what I find is that for most of these patients, you can predict before you do the allergy testing that they'll be negative, that they've got a pretty classic vasomotor rhinitis history. So with vasomotor rhinitis, the triggers are really predictable irritant triggers. So temperature and humidity changes, cold, dry air. These are patients whose nose starts to run as soon as they turn their car air conditioning on, and that cold, dry air is blowing at them and their nose starts to run and they get congestion. When they eat hot and spicy foods, when they're around strong smells like, the perfumes in the shopping malls or cleaning fluids, and even things like exercise can bring on these symptoms. The physical examination varies widely. Again, as was mentioned earlier, they may not have the classic pale nasomucosa that you see with allergic rhinitis, but you'll still see, edema, you'll see clear secretions, you may see signs of postnasal drip like cobblestoning. The investigations are really helpful to rule out allergic rhinitis. So, in these patients, you still will, at least as an allergist, do allergy testing. But again, I'm expecting it to be negative and confirm that my clinical suspicion that they in fact have vasomotor rhinitis. So the mechanism, again, it's not histamine mediated, it's not IgE mediated, it's really neurogenic rhinitis. It's the nerves in the nose are overly sensitive to these ubiquitous respiratory irritants. And this results in really predominant rhinorrhea and a lot of postnasal drip, but they also will have significant nasal congestion. Sometimes there's a misconception that with vasomotor rhinitis, you don't get a lot of congestion, but you do get a lot of congestion as well, but they don't have a lot of inflammatory cells, and that of course can impact treatment. So, somebody was asking earlier today about how do you differentiate between allergic rhinitis and vasomotor rhinitis. And in fact, in one study from the UK, they showed that even just 4 questions can help predict vasomotor rhinitis with a very high degree of sensitivity. Do you have seasonal symptoms? So a lack of seasonal symptoms, of course. Do your symptoms vary when you go from place to place, like on vacations or leaving the cat at home, for example? Do you have a strong immediate family history of allergic rhinitis? And do you notice very specific triggers that set your symptoms off? So again, the person who says, oh yeah, every time I'm around a cat, I sneeze and my eyes bother me. Well, of course, then they've got pretty classic allergic rhinitis. If the patients respond negatively to these questions, then they almost certainly have vasomotor rhinitis. Also, it's much more likely to have non-allergic vasomotor rhinitis if the patients develop their symptoms later in life. I mean, you can develop allergies at any age, but it's not that common too. If you don't have a parental history of allergy, and if you don't have seasonality or symptoms with cats specifically, and if you notice a lot of irritant triggers like perfumes and fragrances. So again, there's a few very simple historical features that can help you suspect vasomotor rhinitis relatively easily. And again, if you look at some of the different symptoms, they very typically will both have rhinorrhea. They all have congestion, basically. But you get more sneezing paroxysms with allergic rhinitis. The itching is a really strong symptom towards allergy. So the patient who has a lot of itching in the nose, not just an irritated nose, but actual pruritus. If they have ocular itching, if they have itching of the palate and the ears, that's of course very typical of allergic rhinitis. And a lack of those symptoms in somebody with a lot of irritant triggers is pretty typical of vasomotor rhinitis. So the treatment, again, I mentioned before, oral antihistamines, which all of these patients are already taking when they come to see you. They've been trying oral antihistamines. And again, once you've already got this part of the story and they tell you that they've been taking Telfast or Arius or Claritin or whatever, you can almost, well, I typically do say, well, I'm sure you didn't find that to be very helpful because they're not going to respond. It's not a histamine-driven phenomenon. Interestingly, though, intranasal antihistamines can be very effective, and not really because of their antihistamine effect, but because they have other effects on the nerves in the nose that are then beneficial for vasomotor rhinitis. One of the classic things with the azolastine spray, whether it's alone or in combination in Dymista, is that it's got a bitter metallic aftertaste. So you have to warn your patients about this because they're not going to like it. And you have to tell them, you won't like this taste. But what I then do is I tell them it's part of how it works. There's something called the bitter taste receptor, and it's important with vasomotor rhinitis. And so when you get that bitter taste, just sort of think to yourself that this means it's working and it's doing something that is going to be beneficial for me. So we try to get them to get through that taste, which is, again, quite unpleasant. Intranasal corticosteroids, again, much like the children with infectious rhinitis, can help in some cases of vasomotor rhinitis, but they're definitely less helpful or less likely to be helpful than in patients with allergic rhinitis or non-allergic rhinitis with eosinophilia syndrome. Basically, in a recent meta-analysis, it showed some benefit after 4 weeks of treatment, but it's not typically maintained. So I don't tend to use intranasal steroids alone for most of my patients with vasomotor rhinitis. However, the combination product in patients who have a lot of congestion or didn't respond to the intranasal antihistamine on its own does work better than either alone for vasomotor rhinitis. So here we've got Dymista, which contains fluticasone propionate along with azolastine, and that combination spray has been shown to be both beneficial and superior to intranasal steroids alone, and very helpful for the patients who are very sensitive to cold, dry air. There are other symptomatic treatments that can be beneficial. Again, intranasal decongestants can help, and it's important, that we don't allow our patients to abuse or overuse decongestants. And, much like short-acting bronchodilators, we have to try to be judicious with their use. However, there is evidence that you can use decongestants for people with really bad congestion for a longer period of time, as long as they're co-administered with a nasal steroid. There are some studies even up to a year of continuous use without evidence of rhinitis medicamentosa developing, as long as they're co-administered with a nasal steroid. And, again, that would not be common and certainly not, top of the line recommendation. But again, if they're used in conjunction with a nasal steroid, there is evidence that longer term use can be considered for selected patients. Again, oral first-generation antihistamines may have some symptomatic benefit for things like postnasal drainage, but again, this has to be balanced with the adverse effect profile on sleep quality and daytime sedation and impairment. And again, unlike the kids that I was mentioning earlier, where you're generally using them short-term during viral illnesses, in this case, you're talking about a chronic condition. So we really don't want to be using medications that have a poor safety profile for a long-term chronic treatment. Intranasal saline, of course, can always be beneficial in these cases. It's certainly very helpful in studies of chronic rhinosinusitis or in patients with sinus disease. It's not been as well studied for purely vasomotor rhinitis, but of course, it's a very safe treatment. And I've even had some patients where I'll end up using nasal irrigation with saline, adding budesonide, Pulmicort, respules to their nasal irrigation for either non-allergic or chronic rhinosinusitis with some improvement. As was mentioned earlier, intranasal ipratropium can be a really helpful treatment for rhinorrhea. Unfortunately, we don't have the sprays here in the UAE, but back in Canada, I used to use the Atrovent 0.03% nasal spray commonly for patients with predominant rhinorrhea or postnasal drip, and it was a very, very helpful treatment to decrease that very bothersome symptom. Again, for vasomotor non-allergic rhinitis, there's really no role for oral second-generation antihistamines. You can use them in conjunction with a decongestant. Something like Clarinase can be helpful because of the pseudoephedrine in it, so that's an option. But really, I'm giving it for the pseudoephedrine and not really for the loratadine that's in it, but that's a potentially beneficial treatment for some patients with bothersome nasal obstruction as well. Leukotriene receptor antagonists are not helpful. Again, I see lots of patients who have been given a trial of Singulair for this problem. As was mentioned earlier, I don't really use it much for allergic rhinitis anyway, because its benefit is pretty minimal, and certainly for non-allergic rhinitis, there's just no role. Cromolyn, allergen immunotherapy, and of course, the biological therapies that we have currently are not effective for vasomotor rhinitis. So to wrap up, I'm just going to circle back to the case that I presented at the beginning. So this is just the same case presentation slide. And I think, looking at her story, I was pretty confident that this was going to be non-allergic vasomotor rhinitis based on her symptom pattern and even the lack of response to treatment. A favorable response to a nasal steroid does not confirm allergic rhinitis. Because again, some forms of non-allergic rhinitis will respond to a nasal steroid. But if somebody's had an adequate trial of a nasal steroid and did not show a symptomatic improvement, then they almost certainly have non-allergic rhinitis. So again, most patients with allergic rhinitis will show at least some response. It may not be satisfactory to them, but they'll have some response. So a lack of response to a nasal steroid is a strong indicator of non-allergic rhinitis. Also, the lack of response to antihistamines. So in this case, of course, she also had no itching. She had no ocular symptoms. She had tried antihistamines lots and never showed any response to them. She had no personal history of atopy. She had had an IgG food test and was avoiding a few foods, and we had a long conversation about that. We did test her for the common aeroallergens, and they were predictably negative. So she was diagnosed with vasomotor rhinitis and started on Dymista. And within a month, she was less congested. She had less rhinorrhea. She had less sneezing, less throat clearing. She was trying to reliberalize some of her diet. And then when we tried to decrease the dosing, I mean, Dymista is a twice daily medication because the azolastine works best administered twice a day. But if somebody's doing well, I'll always say, well, go down to once a day and see how things go. But she noticed more symptoms when she lowered the dosing to once daily. We went back up. She had a few nosebleeds. We worked again a bit on the technique. We interrupted treatment briefly. Her symptoms got worse, so we went back on, and then she was doing well with that. So with that, I'll close the session and open the floor for any questions.